Welcome to this module in which we'll be discussing disorders related to non-reproductive abdominal organs. Once completed with this module, you should be able to define acute abdomen, genitourinary, and renal conditions, list general assessment findings, signs, and symptoms associated with acute abdomen, genitourinary, and renal conditions, discuss various conditions associated with acute abdomen, genitourinary, and renal conditions, differentiate between various types of dialysis, list assessment techniques specific to acute abdomen, genitourinary, and renal conditions, and consider the management associated with caring for patients presenting with abdominal, genitourinary, or renal conditions. You should also be able to appreciate the high level of discomfort that a patient with abdominal, genitourinary, or renal pain will likely exhibit. Abdominal emergencies can prove challenging for EMS providers because the specific cause of the emergency may be difficult to identify. As an EMT, it will be important for you to identify life-threatening abdominal emergencies and provide appropriate treatment. As it can be difficult to determine the cause of an abdominal problem, performing a thorough patient assessment and obtaining a detailed history are important components that will assist the EMT in determining the priority and stability of a patient with an abdominal emergency. Throughout this presentation, reference will be made to acute abdominal, genitourinary, and renal conditions. Such conditions are defined as the sudden onset of severe abdominal pain associated with a wide variety of underlying causes, which will be explored in greater depth within this presentation. Before delving deeper into specific abdominal complaints, we'll begin with a review of abdominal anatomy. The abdomen is the area below the diaphragm above the pelvis. The organs within the abdomen are responsible for digestion, reproduction, endocrine functions, and regulatory functions. The abdomen is divided into 4 quadrants: the right upper, right lower, and left lower quadrants. These terms must be referenced by the EMT when identifying and reporting abdominal signs and symptoms. Remember that left and right refer to the patient's left and right, not the EMT's. It is often common to hear healthcare providers referencing abdominal regions. As the umbilical region surrounds the umbilicus, the belly button, it is the most central region of the abdomen. The epigastric region consists of the upper middle abdominal area above the umbilical region. The suprapubic area is inferior to the umbilical region, superior to the pubic area. The inguinal or left and right iliac regions are on both sides of the suprapubic areas. The diaphragm is the dividing line between the thoracic and abdominal cavities. The rib cage extends down from the chest, thorax, into the upper abdominal quadrants, providing some protection over a portion of the liver on the right and the spleen on the left. The peritoneum refers to 2 similar membranes, the parietal peritoneum, which lines the abdominal cavity itself, and the visceral peritoneum, which covers the abdominal organs. Intraperitoneal structures are contained within the peritoneum. Some of these structures include the stomach, spleen, liver, transverse colon, and ascending colon. The retroperitoneal space is the space between the peritoneum and the posterior abdominal wall. Structures contained in this area include the aorta as it descends through the abdomen, the vena cava, kidneys, descending colon, and the ureters. As far as abdominal organs are concerned, they are commonly classified as either solid or hollow organs. Solid abdominal organs include the liver, spleen, pancreas, kidneys, and ovaries. The liver is the largest abdominal organ. It produces bile, detoxifies the bloodstream by filtering substances, and aids in the production of blood products. The spleen filters blood, recycles old red blood cells, serves as a blood reservoir by storing a significant amount of blood, and assists in fighting certain kinds of bacteria. The pancreas produces insulin and digestive fluids that assist in regulating blood sugar and breaking down proteins, carbohydrates, and fats. The kidneys are vascular organs that filter urea, a waste product from the blood. They also regulate fluid balance in the body and assist with production of bicarbonate, which helps regulate pH levels within the body. The ovaries are female reproductive organs, which are discussed elsewhere in the course. Hollow abdominal organs include the esophagus, stomach, gallbladder, small intestines, appendix, large intestines, ureters, urinary bladder, uterus, and fallopian tubes. The esophagus is a long muscular tube that carries food, liquids, and saliva to the stomach. The stomach holds food and begins breaking it down with acidic gastric juices so the body can begin converting the food into energy. The gallbladder stores bile, which aids in the breakdown of fats. The small intestines continue the work started in the stomach by further breaking down food while also absorbing nutrients. The appendix is located between the small and large intestine. While its function is not well understood, you will see later how problematic an appendix-related emergency can be for a patient. The large intestine reabsorbs water, resulting in the production of feces. The ureters are paired muscular tubes that carry urine from the kidneys to the bladder. The urinary bladder acts as a reservoir for storing urine until it is excreted from the body. The uterus and fallopian tubes are female reproductive organs. Their function is covered in greater depth in a different module of this course. When conducting an assessment of a patient with abdominal complaints, pain is a very common finding. The pain may be referred, meaning it is felt in a location other than where the problem actually exists. The pain may be parietal, meaning it is originating from the parietal peritoneum. Due to irritation or inflammation of the parietal peritoneum, such pain is typically localized, sharp, and intense. The visceral peritoneum may also be involved, resulting in what is known as visceral pain. This pain originates from irritation or inflammation of abdominal organs and is commonly described as being a diffuse, not localized, dull or achy feeling. Patients may also experience tearing pain, which is described as a sharp, ripping feeling like body tissues are physically being torn. When evaluating abdominal pain, remember to use the OPQRST mnemonic to identify the onset, provocation, quality, radiation, severity, and time associated with the pain. More detail on an OPQRST history will be provided a little later in this presentation. Patients may also present with complaints of nausea, vomiting, hematemesis, the vomiting of blood, melena, dark tarry stools, hematoschisia, the passage of fresh blood, diarrhea, constipation, bloating, anorexia, loss of appetite, abdominal tenderness, distension, guarding or rigidity, signs of shock, fever, chills, indigestion, urinary frequency or burning, and weight loss. Conditions associated with acute abdominal, gastrointestinal, genitourinary, or renal complaints include peritonitis, appendicitis, pancreatitis, cholecystitis, bowel obstruction, hernia, gastrointestinal bleeding, ulcers, diverticulosis, diverticulitis, esophageal varices, abdominal aortic aneurysm, kidney stones, urinary catheter complications, and kidney renal failure. As a part of this presentation, we'll be discussing each condition in turn. The first abdominal condition to be discussed is peritonitis. Peritonitis, a potentially life-threatening condition, occurs when the peritoneum, the membrane that forms the lining of the abdominal cavity, becomes inflamed. Medical causes for peritonitis include rupture or perforation of the abdominal wall, appendicitis, pancreatitis, and peritoneal dialysis. Peritonitis may result following trauma when bacteria enters the abdominal cavity or from internal injuries where gastric juices, blood, or bowel contents irritate the lining of the abdominal cavity. Signs and symptoms of peritonitis can include nausea, vomiting, abdominal bloating, high fever, chills, pain, and abdominal rigidity, where stiffness of the abdominal muscles can be felt. Peritonitis may lead to sepsis, which is a serious infection throughout the body, and shock. Appendicitis occurs when the appendix becomes inflamed. Causes may include the appendix being blocked by feces, a foreign object, or, in rare instances, a tumor. Appendicitis is often resolved through surgical removal of the appendix. Signs and symptoms may include nausea, vomiting, fever, chills, anorexia, rebound tenderness caused by peritoneal irritation, and pain. To assess for rebound tenderness, press down gently and firmly in the right lower quadrant and remove the pressure rapidly. If the patient experiences pain when the pressure is released, he or she is said to have rebound tenderness. These patients may initially experience generalized, dull, diffuse pain around the umbilical area, which later progresses into sharp pain commonly localized in the right lower quadrant. One of the major concerns with appendicitis is that the appendix can ultimately rupture, resulting in bowel contents being released into the abdominal cavity, which leads to even greater problems for the patient. A significant increase in pain is common in such instances. Patients with appendicitis may also develop an abscess, peritonitis, or shock. Pancreatitis is the inflammation of the pancreas. This condition is common in patients with chronic alcohol consumption, although it can also be caused by an obstructing gallstone or other disease. Signs and symptoms of pancreatitis may include nausea, vomiting, fever, and severe pain. The patient may have referred pain in the epigastric and umbilical areas that radiates to the back and shoulders. If left untreated, pancreatitis can lead to sepsis, hemorrhage, and shock. Cholecystitis occurs when the gallbladder becomes inflamed. This is commonly caused by gallstones, which prevent bile from leaving the gallbladder, resulting in inflammation. Signs and symptoms of cholecystitis may include sudden, severe right upper quadrant pain, epigastric pain, referred right shoulder pain, nausea, vomiting, abdominal bloating, and belching. Symptoms usually occur approximately 30 minutes after eating a fatty meal, given that bile is used by the body to help emulsify fatty foods for digestion. Complications may include gallbladder rupture, infection, pancreatitis, and peritonitis. Depending on the nature of the cholecystitis, the patient may ultimately need a cholecystectomy to have the gallbladder removed. A bowel or intestinal obstruction occurs when there is a partial or complete blockage of the hollow space within the intestines. Such a blockage prevents contents within the intestines from passing through. Potential causes include a hernia, adhesions, impacted feces, foreign bodies, twisting of the intestines, referred to as a volvulus, or overlapping of the intestines, called intussusception. Signs and symptoms may include diffuse visceral pain that is poorly localized, nausea, vomiting with a fecal odor, abdominal distension and/or fullness, constipation, and diarrhea. Complications may include tissue infarction, death, a ruptured bowel, peritonitis, or shock. A hernia is a sac that forms when a hole or weak area in the muscle layers of the abdominal wall allow a portion of the intestine to protrude. A few types of hernias include umbilical hernias, hiatal hernias, and inguinal hernias. Hernias are routinely caused by conditions that increase pressure on the abdominal wall. Some of these conditions include heavy lifting or straining, a chronic cough, peritoneal dialysis, and undescended testicles. Signs and symptoms may include pain or discomfort along with an abdominal or groin mass or lump. If the hernia becomes strangulated, which occurs when the sac becomes stuck inside the hole and blood supply is cut off, the patient will need emergent surgery. A hernia may also lead to a bowel perforation, resulting in air and bowel contents leaking into the abdominal cavity. Gastrointestinal bleeding is bleeding anywhere within the GI system, from the esophagus to the rectum. GI bleeding is a symptom of another disease, not a disease itself, and there are multiple conditions that can cause upper GI bleeding, from the esophagus to the small intestine, and lower GI bleeding, from the small intestine to the rectum. Upper GI bleeding may result from esophageal varices, esophagitis, a Mallory-Weiss tear caused by vomiting, or a stomach ulcer. Causes for lower GI bleeding include colon cancer, diverticulitis, ulcerative colitis, or hemorrhoids. Signs and symptoms may include melena, dark tarry stools, hematoschisia, the passage of fresh blood from the rectum, bloody streaks in feces, or hematemesis, vomiting of blood. Coffee ground-like emesis may be noted, and rectal bleeding may be dark or bright red, depending on where the bleeding is in the GI tract. GI bleeding usually also has a very distinct pungent smell. Complications associated with GI bleeding include anemia, low red blood cell count, hypovolemia, and shock. While there are several types of ulcers, those involving abdominal complaints are typically peptic ulcers, which are painful sores in the lining of the stomach or small intestine caused by digestive acids. The type of ulcers we'll be discussing in this slide are peptic ulcers. Causes may include bacterial infection with Helicobacter pylori, high daily routine doses of nonsteroidal anti-inflammatory drugs such as Advil or Aleve, smoking or other conditions that cause excess acid production in the stomach, and drinking too much alcohol. Signs and symptoms commonly include epigastric pain described as a gnawing or burning, melena, dark or tarry stool, hematemesis, vomiting blood, and coffee ground emesis. Complications may include internal bleeding, obstruction or perforation of the stomach or intestines, and peritonitis. Diverticulosis occurs when pouches, diverticula, form in the wall of the colon. Diverticulitis occurs when the bulging sac or pouches, diverticulosis, become inflamed or infected. Eating a low-fiber diet, given the proliferation of processed foods, is thought to be a main cause of diverticulosis. The theory is that a lack of fiber contributes to constipation, requiring more intestinal contractions during a bowel movement, which increases the pressure in the intestinal wall, producing bulges that form the pouches, diverticulosis. Diverticulitis then occurs when small pieces of feces become trapped in the intestinal pouches, resulting in inflammation or infection. Signs and symptoms may include lower abdominal pain or tenderness, bloating, gas, fever, chills, nausea, or vomiting. Complications can include abscess formation, perforation or tearing in the colon, or a narrowed area in the colon. Esophageal varices are enlarged veins in the esophagus walls that may bleed. Esophageal varices occur when the amount of pressure within the blood vessels surrounding the esophagus increases. This condition may occur as a result of chronic alcohol consumption, caustic substance ingestion, cirrhosis, or liver disease. Signs and symptoms of liver disease may include fatigue, weight loss, jaundice, a yellow discoloration of the skin, anorexia, and edema in the abdomen, referred to as ascites. Patients with esophageal varices may not have any symptoms, or they may present with melena, black tarry or bloody stools, pallor, complaints of a burning or tearing sensation in the throat, hematemesis, vomiting copious amounts of bright red blood, or hypotension and tachycardia given significant blood loss. Complications include hypovolemic shock and infection. Rupture of the esophageal varices can be life-threatening for the patient given resultant airway compromise and the loss of a considerable volume of blood. An abdominal aortic aneurysm, also referred to as a AAA, is a weakening in the wall of the abdominal aorta leading to ballooning or an enlarged, dilated area in the abdominal aorta, making it susceptible to rupture. The exact cause of a AAA is unknown, but risk factors are believed to include genetics, obesity, high blood pressure, and smoking. It is possible for a person to have a AAA without knowing, given a lack of any signs or symptoms. If the AAA begins to tear, called a dissection, or rupture, however, the patient will commonly experience pain in the abdomen or back, described as sharp, tearing, excruciating, or a combination of those three. Additional signs and symptoms may also include hypotension, tachycardia, clammy pale skin, and or a pulsating abdominal mass. Complications from a AAA may include aortic dissection, aortic rupture, hypovolemic shock, or even death. Kidney stones are small, hard stones of various size that form in the kidneys and travel from the kidneys through the ureters into the bladder to be expelled through urination. There are multiple causes of kidney stones, such as gout, urinary tract infections, certain medications, or an excess of calcium and other substances that combine and crystallize. Signs and symptoms commonly include severe flank pain that may radiate to the groin, nausea, vomiting, hematuria, blood and urine, and agitation or restlessness are also possible. Complications may include obstruction of the ureter, urinary tract infection, and kidney damage, which may result in a decrease or loss of kidney function. Urinary catheters are thin tubes placed in the bladder to drain urine. The urine drains through the catheter tubing into a collection bag. Urinary catheters are used when patients cannot urinate on their own or suffer from urinary incontinence, leakage. They are also used during and after surgery and to measure urine output, which can be common for a patient in the intensive care setting. Complications associated with urinary catheters include catheter-associated urinary tract infections, bloodstream or kidney infections, and trauma resulting from a dislodged catheter. Signs and symptoms of a catheter-associated urinary tract infection include dysuria, painful urination, hematuria, blood in the urine, fever, chills, frequent urination, and foul-smelling or odorous urine. To prevent infection, the following should be done by the patient, caregivers, and healthcare personnel. Hand washing before and after touching the catheter or urine, using proper technique and procedures for daily catheter care, keeping the collection bag below the level of the bladder to prevent urine from re-entering the bladder, and avoid tugging, pulling, twisting, or kinking the catheter. When caring for a patient with a urinary catheter, the EMT should wear gloves, assess for signs and symptoms of a urinary tract infection, keep the collection bag below the level of the bladder during transport, and ensure the catheter tubing is not tugged, pulled, twisted, or kinked. Kidney or renal failure occurs when the kidneys lose their ability to adequately filter the blood. Stated another way, the kidneys are no longer able to remove the toxins and excessive fluid from the body. Kidney failure can result from a variety of factors, with hypertension being the most common. Signs and symptoms of kidney failure may include little or no urine production, weight gain related to fluid retention, altered level of consciousness given the buildup of toxins in the body, and shortness of breath related to edema and a backup of fluids into the lungs. Complications of untreated kidney failure include permanent kidney damage and eventual death. Aside from a kidney transplant, patients with renal failure commonly require temporary or lifelong dialysis to continue living. Hemodialysis is the process of mechanically filtering blood to remove toxins and excess fluid from the body. Complications or adverse effects of hemodialysis may include hypotension, muscle cramps, nausea, vomiting, hemorrhage, and infection, especially at the access site. Hemodialysis access devices include shunts, such as a fistula that connects an artery to a vein, usually in the arm, or a graft that connects an artery and vein with an implanted tube, commonly in the forearm. A venous catheter may be used for hemodialysis in some instances, whereby a tube is placed in a vein, usually in the neck or chest, for access. As these devices modify the body's circulatory system and pathways, the arteries and veins, the EMT should avoid performing any interventions, such as a blood pressure or injection, on the arm containing any of these access devices. If a patient misses dialysis, he or she may experience weakness, develop pulmonary edema, a buildup of fluid in the lungs, or have fluid and electrolyte imbalances. Another form of dialysis is peritoneal dialysis. Peritoneal dialysis is for patients who manage their renal disease from home on a daily basis through the use of a permanent catheter that is implanted through the abdominal wall into the peritoneal cavity. While peritoneal dialysis also removes toxins and excess fluid from the body, it does so using a dialysis solution that is infused through the catheter to be drained after a set amount of time and discarded. EMT providers should wear a face mask if they are working near a peritoneal catheter. Complications of peritoneal dialysis include infection at the catheter site and peritonitis. When managing a patient with a dialysis emergency, begin with the ABCs. Support ventilation if necessary, and also ensure the patient is not bleeding from the access site. If bleeding is present, it must be controlled. Direct pressure and elevation should be used first to address bleeding from the access site. Hemostatic dressings may also be employed. If absolutely necessary, a tourniquet may be considered, but only after consulting with medical control, as a tourniquet may damage the access device, leading to additional complications for the patient beyond the immediate emergency. When transporting the patient, be certain to recognize whether the patient is in shock or has pulmonary edema. The patient in shock should be transported supine, while the patient with pulmonary edema should be transported sitting or in Fowler's position. Given that background knowledge on different abdominal complaints and etiologies, it is now time to focus on the steps associated with conducting a thorough, focused abdominal assessment. Assessment of a patient with abdominal-related complaints begins with ensuring body substance isolation precautions are followed and a thorough scene size-up is completed. Ensure the scene is safe for EMS providers. Determine the mechanism of injury or nature of illness, number of patients, the need for any additional resources, and the need for cervical stabilization. Continue the process with a primary assessment to obtain a general patient impression. Ensure adequate airway, breathing, and circulation. Determine responsiveness. Establish a baseline level of consciousness. Obtain the patient's chief complaint, and identify any immediate threats to the patient's life. Be certain to obtain the patient's history and begin performing a secondary assessment with an emphasis on the abdomen given the patient's abdominal-related complaint. Visually inspect and palpate the abdomen. Look for distension, bloating, discoloration, and protrusions. If trauma is involved, be certain to also perform a DCAP BTLS assessment, looking for deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Ask the patient or family members if his or her abdomen appears normal as well. Palpate the abdomen by using the fingertips to apply gentle pressure on the abdomen in the 4 different quadrants. If the patient has complaints of pain in a specific quadrant, palpate that quadrant last. Be certain to note any tenderness, pain, rigidity, hardening, or masses while palpating. If palpation increases the patient's pain, be sure to note that as well. If a pulsating mass is noted, do not palpate that area. Such a mass may be indicative of an abdominal aortic aneurysm, and palpation may result in a dissection or rupture. This is a life-threatening emergency that requires immediate transport. While it used to be normal for EMS providers to learn about assessing bowel sounds, current practice is to forego that assessment. Assessing bowel sounds is time-consuming if performed correctly, up to 3 minutes per quadrant, and the information garnered from such an assessment, whether bowel sounds are present or absent, has no significant impact on the pre-hospital care provided. Remember to obtain vital signs as well so that an appropriate field impression and subsequent treatment plan can be developed. Document all interventions along with the patient's response to those interventions, and be certain to reassess the patient at appropriate intervals. Depending on the nature of the emergency, it may be prudent to consider ALS intervention. It is very common for patients with abdominal problems to experience pain associated with their underlying illness. Given the difficulty that can be involved in diagnosing abdominal complaints, a thorough assessment related specifically to the patient's pain can prove to be an invaluable tool. In obtaining a history of the patient's present illness, remember to use the OPQRST mnemonic when assessing his or her pain. O is onset, which refers to when the abdominal pain or discomfort started. Questions to ask include, when did this pain or discomfort begin? Did it begin while at rest or during activity? Did the pain begin as steady and severe, or did it gradually build to this point? P stands for provocation in terms of what provokes or affects the pain. Ask the patient, does anything make the pain better or worse? Does any position make the pain better or worse? Does movement affect the pain? Is there any rebound or other tenderness? Q refers to the quality of the pain. More specifically, how would the patient describe the pain? Ask the patient to describe the sensation in their abdomen. Is the patient experiencing discomfort or pain? If pain, does the patient describe it as sharp, dull, stabbing, aching, tearing, etc.? R is radiate. When asking about radiating pain, the EMT is interested in whether or not the pain travels or is felt somewhere else. Be cautious when asking about radiated or referred pain because many patients do not know what the EMT means when he or she asks about radiating or referred pain. Rather, ask the patient if he or she has pain or discomfort anywhere else. S is for severity. Ask the patient to rate his or her pain on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain he or she has ever felt. Some services prefer to use a scale of 0 to 5, or 1 to 10, or 1 to 5. Use whatever scale is prescribed by your local protocols. Also be sure to be consistent when choosing a scale, as it will be important to ensure the same scale is being used throughout the transport. If the EMT knows the scale used by the transport destination, it may be prudent to use that pain scale throughout the assessment and transport. This is obviously a subjective scale from the patient's perspective, mind you, but the results are still important. When assessing severity, do not hesitate to differentiate the pain over time. For instance, the patient's pain may increase with movement or palpation, Find out how the patient rates the pain when sitting still, then ask how he or she rates the pain when moving or upon palpation. Be certain to document the patient's responses over time. Not only does the initial response provide a baseline number, but subsequent responses establish a trend to show if the pain is increasing, decreasing, or remaining the same. Also be certain to include the scale itself within any documentation. A patient pain rating of 5 is very different given a scale of 0 to 10 as opposed to a scale of 1 to 5. Lastly, T refers to time. It is important to know when the complaint started and whether or not any changes have occurred since that time. Diffuse abdominal pain over the course of days is not the same thing as a rapid onset of sharp right lower quadrant abdominal pain. The time frame is important to note and document. Ask the patient how long he or she has had the pain or discomfort. Find out if it has changed over time and, if so, whether the change has been for the better or worse. The last component to discuss within this module is the management of patients with abdominal-related complaints. As with any patient, regardless of the complaint, airway management is of primary concern. If necessary, clear and maintain the patient's airway, which could include suctioning. Remember, many of these patients will complain of nausea, and vomiting is a possibility. Administer oxygen as appropriate. These patients should not eat or drink anything while in the EMT's care. This is even more important if their condition necessitates surgical intervention. When transporting, try to keep the patient in a position of comfort. If the patient prefers a fetal position, try to accommodate him or her while also ensuring an adequate airway and proper securing to the cot with straps or seat belts. Depending on the nature of the abdominal complaint, be prepared to treat for shock and consider whether or not ALS intervention is warranted. As far as abdominal complaints are concerned, advanced life support providers have the ability to initiate IVs, provide fluids, administer antiemetic medications to prevent nausea and vomiting, control pain, and address shock with additional skills and treatments. Do not worry about diagnosing the cause of abdominal pain in the field. In many instances, expensive diagnostic equipment and tests are required to determine the cause of an abdominal complaint. As an EMT, it will be your job to provide prompt assessment, intervention, and transport for the patient with an abdominal-related complaint. Provide a detailed assessment and document thoroughly to assist emergency department and other healthcare staff in treating the patient. Given your completion of this module, you should now be able to define acute abdomen, genitourinary, and renal conditions. List general assessment findings along with signs and symptoms associated with acute abdomen, genitourinary, and renal conditions. Discuss various conditions associated with acute abdomen, genitourinary, and renal conditions. Differentiate between various types of dialysis. List assessment techniques specific to acute abdomen, genitourinary, and renal conditions. Consider the management associated with caring for patients presenting with abdominal, genitourinary, or renal conditions. And appreciate the high level of discomfort that a patient with abdominal, genitourinary, or renal pain will likely exhibit. This presentation was created by Waukesha County Technical College with grant funding from the Wisconsin Technical College System.